Hey folks, Scott Weingart here, and this is an EMCrit podcast. This is actually an updated podcast. This is the update to the intubation checklist. We talked about, I don't know, it had to be at least a year, if not more. And I've taken in all the feedback, all of the comments, all of the edits I've made personally, all of the updated stuff. And this is the simplified, easier, better, newer 2.0 version of the EMCrit RSI checklist. And of course, it's all about how to stop killing our patients while intubating, and checklists help do that. This was the old checklist. Few comments we got about it. Can there be some stuff we can eliminate? Let's make this quicker. Let's make it easier. There's some stuff that we already know, and you could take it out. And can you combine things? Can you make it smaller? Also, can you make it fit onto a tiny card that we could put behind our ID or keep in our pockets as opposed to having to have a full 8.5 by 11 sheet? A comment I got that I don't quite understand is people are like, well, this is not a checklist. All this stuff is like reference material. That it's supposed to be folded over at that dotted line. You're not supposed to be seeing that when you're using it as a checklist. It's just this top portion up here, that's the checklist, and this would be on the back, but it still confused people, and let's make it easier. And along those lines, a gent called Vahiender, I'm so sorry if I'm mispronouncing your name, but I have your Twitter handle linked in the show notes for this, emcrit.org/176. He sent me this. He's like, I took your checklist and I made it something that could fit in my pocket. What do you think? And I said, I think that's good. Let's see what we could do to work with that. And so this is here in front of you now, the updated, the new, the better EMCrit RSI checklist. And we will go through it step by step. But you can see, yes, it's big on the screen, but it's made to be printed on a card the size of a business card or an ID card, fit in your pocket, easy peasy. So the top portion, the plan. Let's go through them one by one. Physio issues considered. These are the HOP killers, the hemodynamic kills, the patients who are already hypotensive or shocky or have the potential to become, like any septic patient you're intubating, regardless of what their blood pressure is now, has a nice potential to drop their blood pressure. Just as a side note, we now have one paper to go along with what my friend Rory Spiegel suggested would be a good way to go, which is if you look at the IVC and it's collapsing with each breath, that's a patient who may decompensate during the intubation. I'll put that in the show notes. We have a piece of literature, not great literature, but good literature to support that. So maybe that's something you should look at. Oxygenation kills. Is the patient requiring CPAP or they're not satting all that great? Well, they'll probably get worse, not better, during the intubation attempt itself until you recruit those alveoli. And then, of course, the P of HOP killers is pH issues. Patient with severe metabolic acidosis who's compensating with a Kussmaul or a respiratory alkalosis who you come and paralyze may decompensate during the intubation. So this portion of the checklist asks you to consider those things, and later on in the checklist there's some ways of addressing them. But just getting them in your mind, oh, wait, crap, this patient may drop their blood pressure, makes you think in a much better way. So that's why it's there. Induction agent muscle relaxant. You will never forget to have this, but you may forget to ask for it at the beginning of your intubation preparations, which is when you want to ask for it so it's actually there, as opposed to being, oh, everything's ready, hand me the meds. What meds? You didn't ask for any meds. What's wrong with you? So that's why that's number 2. Okay, there's your HOP killer stuff. And this is how we want the syringes labeled, at least at my shop. I want to have a, not scribbled, with pen on a curved surface. That doesn't work. I want a easy to read label. And I want it to be in the proper format, which is milligrams per ml. That's what I want. I don't want, here's a syringe full of 200 milligrams propofol, because if I use 2 cc's of it, it's not true anymore. This way I can look at the label and know exactly what's there. I look at the label, I said 10 milligrams per ml of ketamine. There's 8 mLs in here. I know exactly what I got. I got 80 milligrams. And further, we don't want this to be like, how much ketamine and how much rock do you want? That's a cognitive load you don't need at the point you're asking for the meds, because the patient's situation may change by the time you're actually ready to administer them. So the way this should happen, and the way we've specified at our shop, is there's standardized amounts of every medication. That's what you're given. So you're given 10 cc's of rock. You're given 10 cc's of succinylcholine. You're given 20 cc's of propofol. You're given 20 cc's of ketamine, even though this picture's just shown 10 just for education purposes. You're given 10 mLs of etomidate, et cetera, et cetera. And then you're just handed that, and then you could decide what to use. And if you need more, because you have a grossly a morbidly obese patient, then sure, you could ask for, I'd like 2 sticks full or 2 syringes full of etomidate, no problem. But you don't have to figure out exactly what you're going to use before you're ready to use it. And we have pre-printed labels. I could share these, and that's how we do it. All right, ask for the post-tube analgesia sedation now. You don't have to wait to intubate until it comes, but at least now you've sped up the process of getting it by 5 or 6 minutes. At our place, there's always extra nurses, so sending an additional nurse to the med room to mix up the post-intubation stuff is a good use of time. Okay, plus or minus push-dose epi. And this depends on your assessment of the hop killers, with the key one being the hemodynamic killer. I have a whole podcast about this. But if you think the patient has any chance of decompensating, either from a heart rate or a blood pressure perspective, then just mix up some push-dose epi. Easiest thing in the world. If you look on our sheet, and it's kind of blurred out here due to the beauty of photography, but this was another suggestion from a listener. We actually have an epinephrine label. It says 10 micrograms per ml, and the mixing instructions are actually on the label itself. So it says, take a 10 ml flush, eject 1 ml, so you have 9 ml flush, and draw up 1 ml of cardiac, 1 to 10,000 epinephrine. It's there on the label. So if you have the label, you know how to mix it. You don't need anything else. This was brilliant, and I'm so sorry I'm forgetting who suggested this, but this is beautiful, and I'll put that in the show notes as well. All right, that's push-dose epi. Failed airway plan verbalized. This is key, not just having a failed airway plan, but saying it to everyone in the room. So either the supervisor or the actual person doing the intubation has to say every step of the failed airway plan. If you have your own, or if you use like Nick Crime's Vortex, then verbalize that. But for me, it will be always the shock trauma failed airway algorithm. I've updated it because this, of course, is the EMCrit remix. This is the newest version of the EMCrit remix. I think it's damn near perfect. It is very similar in mindset to Vortex, and Vortex has always been very similar in mindset to the way I think about things. But I like the linear progression for emergency and critical care. I don't need to choose between any of the options of BVM or laryngoscopy or supraglottic. I want a straightwise progression through it. And that's why I like this better, and that's why I continue to use this. But you can see this is updated. I'll have the full version of this in the show notes as well, but just to go through it very quickly, since I work in a trainee shop, we'll allow 3 laryngoscopies, assuming we could keep the patient's saturation good between the attempts. And laryngoscopy number 1 is dealer's choice. You can let a resident do it. You can let an intern do it. They can use whatever they want. They use direct. They can use video, though I always urge use video, and you can use it as either direct or video, depending on your preference, depending on whether you're looking at the screen. But what's in the mouth should always be a standard geometry video device. If you fail, laryngoscopy number 2 still could be a resident. I would very strongly consider adding a bougie. I'd very strongly consider doing video if the first one was direct, as in turn the screen towards them. And if both of those fail, there could be one more attempt. It doesn't mean you have to do 3 attempts, but there can be a maximum of 3 attempts. And that third attempt is attending only, or best intubator in the room only. I would say it's with every possible perfection of the technique, if you haven't already done that, which you should, which means perfect positioning, bougie, standard geometry video, and potentially optimizing techniques like lifting the head still further, front of the neck optimization with thyroid manipulation. And really, it should be a perfect attempt, because this should be it. You get 3. And then you stop with laryngoscopy crap, because you're going to move on to other things. And what you're going to fail to is the intubating supraglottic. If you don't have an intubating, then use whatever supraglottic. But I really feel you should be using 2nd or 3rd generation devices, which means they have a gastric port and they allow easy intubation through them. For us, currently, it's the iGel. And you should place that. And if you fail at that, you move to surgical airway. No more bullshit. But if you're able to get good SATs with the intubating supraglottic airway, then stop, regroup, get everything back to a healthy state of mind. Get the patient's SATs up to 100. Get them well denitrogenated. Get them in a perfect physiologic state, optimize blood pressure, what have you. This is what's called the green zone in the Vortex approach. And then you can try additional laryngoscopy attempts if you're going to learn from your mistake. You can choose to take out the supraglottic and try again, or have someone else try again after everything's back to beautiful, beautiful condition. Or you could just intubate through that supraglottic. If that fails, if the patient's SATs don't improve, then obviously you go back to surgical airway. That's the updated EMCrit remix of the shock trauma failed airway algorithm, which to my mind or to my understanding, is still the only somewhat validated difficult airway approach out there, as opposed to all the others, which sound good, but no one's actually studied them. All right, CRike evaluation, the last part of the box for plan. This involves CRIKE 2, which I've discussed in previous podcasts, so I'll go through it really quickly. Every patient you intubate is at least in the green zone of the CRIKE 2. And what that means is every patient you intubate, you discuss that the end stage of your failed airway plan is surgical airway, front and neck access. You felt the anatomy. You feel it coming up from the sternal notch upwards, not coming from the chin downwards, or else you surely will be in the hyothyroid. So you felt the anatomy, you know what you're dealing with. And if you don't feel any anatomy, then you know you're going to have to make a bigger incision. And you visualize the kit in the room. It doesn't need to be right at the bedside. It doesn't need to be open, but it is there. And that visualization might have been you checked your locked airway cart and it's there. But that's green. That's every single patient. And of course, the kit, as you know, if you listen to EMCrit, is simply a scalpel, a bougie, and a set of endotracheal tubes that includes a 6.5 cuff tube. That's it. That's all you need. Yellow is a patient predicted to be difficult, but you've still decided to go forward with RSI. And for those patients, you'll mark the neck. And the mark, yes, maybe it'll help you find the anatomy a little quicker, but that's not what it's for. It's psychological. If you mark the neck, everyone in the room knows this is for realsies. And you violated the patient's personal space. You've drawn a mark on them. It breaks down the barriers to you doing the CRIKE. And now the kit's at the bedside, which means you see a bougie, you see a scalpel, and you might even want to put the 6.0 Portex trach there at the bedside. You don't necessarily need to open them. They're there on a table, ready to go. Red is where you've already failed 2 laryngoscopy attempts. Maybe you're trying a third, maybe you're trying a supraglottic airway, but you're feeling this is going to a bad place. The patient's sats are not great. There should be someone already ready with an open scalpel in hand, their hand on the thyroid cartilage, the kit, the rest of the stuff they need open, ready to go next to them. There's a Ruben Strayer's slide of a marked neck, and also the double suction technique where people are doing your suction for you because they're looking at the same screen you are. Great, great stuff. Okay, that was the plan. Let's go to the patient box. Denitrogenated for greater than or equal to 3 minutes. This is separate than pre-oxygenation. I put pre-oxygenation as the saturation reading, which we'll get to in a sec, and denitrogenation is getting the nitrogen washout of the alveoli, and for that it's purely time. You need a high FiO2 source, which for me, non-rebreather plus nasal cannula, or CPAP mask plus nasal cannula, or BVM with PEEP valve plus nasal cannula. And Sam, I will do this week the little wee on why the evidence is very good, not bad for denitrogenation, and for APOX with the nasal cannula at 15. So don't worry, I'm getting there. 3 minutes, high FiO2 source, regardless of the pulse ox. And this reminds you again to put that nasal cannula on at 15 liters per minute underneath anything else you do for apneic oxygenation. Now here's where the pre-ox part comes up. Have you got their sats to greater than or equal to 95%? And if you haven't, with whatever else you were doing, then consider putting them on CPAP somewhere between 5 and 15 centimeters of water to see if you can get those sats up greater than or equal to 95%. And if you get to 15 and you still can't do it, then you have no choice. You have to go forward, and you may choose to RSI. You may choose to do them awake and leave them spontaneously breathing. All right, the next step is to look in the mouth, see what you got in there, what's the teeth situation. It's going to catch on your laryngoscope blade. Do they have dentures? If they do, leave them in case they need to be bagged during the apneic period. Take them out right before you intubate. And then arrange the neck, assuming they're not in spinal precautions, and see, because if they have spinal fusion or some kind of arthritic disease and you can't move the neck at all, that's going to be a tougher intubation. Positioning. We know this. Face plane parallel to the ceiling with the ears horizontally aligned to the sternal notch. Thank you, Rich Levitan. There you go. And this patient, impossible in that situation on the top and pretty easy on the bottom side. All right, pulse ox, visible or audible? And the anesthesiologist, they like it audible. I don't like that. I like seeing the pulse ox. How do you do that? Well, it's always, the monitor always is positioned behind your head. So unless you have eyes in the back of the head, you don't see it. Some people have suggested putting a screen up at the entrance of the resuscitation bay, because that always is where you're facing, and just mirror the screen. And you could do that. You could do that wirelessly. It's not that tough. Or you could just think outside the box. by which I mean, for the purpose of the intubation itself, just turn the entire stretcher slanted away from its normal position, and all of a sudden, you, the supervisor of the intubation, and everyone in the room could see the monitor, and just as importantly, could see the end tidal CO2 tracing. So just turn your stretcher near horizontal to the screen, and everyone could see now. It's gorgeous, it's fun, it's easy. All right, and then reliable IV access, preferably 2, but it should be tested. It should be slammed with a flush and make sure it ain't blown. And if you're having any issues, you don't mess around. You just put in an IO, you intubate, and then you'll get access after. All right, the third box, equipment. There's a kit dump on the table. What does that mean? It means there's nothing on the patient's chest, on the bed, on some tiny little crappy Mayo stand somewhere. You have a real size table next to you at either the supervisor's or the intubator's hand, ready to go. These things are useless. Do not put anything on them. Throw them away. This is what they do in EMS. They get 360-degree access, and they dump their kit in a way where everything is immediately accessible and available. We do the same thing in the hospital. We get a big table. This is our kit dump kit. I love it. If you don't have this, no problem. Just put everything on a big table, laid out, ready to go. This is the other side. This is where we have our difficult airway equipment, our supraglottics, our bougies, and our surgical airway equipment. All right, prep your BVM. People really screw up BVM ventilation, so make it as easy as possible. And you'll see BVM on oxygen, plus or minus PEEP valve, and then waveform capnograph on the BVM. Those two parts lead to this. This is a BVM. Ours is lovely because we have a pressure gauge there, keep you from going into 80 centimeters of water. There's our PEEP valve, there's our one-way valve, and there's our waveform CO2, which means every breath delivered with this device, whether it be to a spontaneously breathing patient, a patient we're bagging, a patient we're ventilating through a supraglottic, or a patient we're ventilating through an ET tube, we get immediate confirmation that the breaths are working with waveform end tidal CO2. A video laryngoscope. It doesn't mean you need to use it. Your choice, but it better be in the room. I think every intubation that is currently done should be done with a video laryngoscope in the room, and whether you choose to use it or not is up to you. And if you have a standard geometry blade, there's no reason not to do it, because the light is better than any laryngoscope out there. It's gorgeous, and then you only have to look up at the screen to convert from direct laryngoscopy to video, or vice versa. So that's my rec, but if you want to use a standard laryngoscope, no problem. I think a video laryngoscope should be in the room. And there's your non-video laryngoscope right there on the checklist. Make sure there's a backed up laryngoscope, standard geometry, regular, Macintosh, old school blade. We have disposables now that I love, and it means I don't have to worry about checking. Does the light work? Does the battery work? Because it always works now. All right, on your table, you have an oropharyngeal airway. And honestly, the sizing doesn't matter because the purpose of this device is not to keep the tongue forward. It might help with that, but that's really should be a good head tilt, chin lift, or jaw thrust. It's to keep the teeth open so that when you're ventilating, you're not ventilating in a dead space because the nose is filled with a nasal cannula. And if the mouth is not kept open, when you do the head tilt, chin lift, it closes. That's why the oropharyngeal airway is there. Always a bougie at every single intubation. Always a supraglottic airway, preferably an intubating supraglottic airway, present at the bedside for the right size for the patient on that kit dump table. And then a scalpel. And I don't care if it's an 11 or 10, whatever you like, but it's there. And all the stuff's laid out on that table so that if you need it, you don't have to ask anyone for anything. And then 2 suctions tested and checked. Last box, the team. Anyone around the bedside has, I'm skipping around, eye face protection on because you will get splattered, especially if you go surgical. And then this top box, you've briefed someone for external laryngeal manipulation, which means you say, okay, if I ask you to put your hand on the neck, you'll put it right on this thyroid and you show them where it is, and you say, just let me move you wherever I want, and you keep your hand there. Brief someone for head elevation, meaning you tell them, look, if I lift the head to get a better view and I say, take this over, you just keep the head in the exact position I put it. And then if the patient's in inline stabilization, you've briefed someone on the proper way to do that. And as we talked about with George Kovach, that means earmuffs. Have them put their hands over the patient's ears, and their job is to keep you from lifting the head off the bed. That's their only role. And if you tell them to let up, they let up. That's the briefing, because sometimes getting the airway is more important than whether or not the head moves off the bed by 2 inches. And if you say let up, they better understand they need to do that. There you go. That's the new checklist. I'd love to hear what you think, any suggestions, any improvements. And that's it. EMCrit.org/airway has everything EMCrit Airway in one place, and you can find all sorts of good stuff there. All right, if you want to hear the actual 45-second use of this, then just go to EMCrit.org/176, and you'll see a recording of this actually in use, so as opposed to the explication, the actual utilization. Scott Weingart, EMCrit Podcast, saying bye-bye.